I've given one of these talks on Zoom, from a Zoom standing. I've taught before, but not one of the treats talks. But anyway, I'm glad to be here. We're glad to do this today. This is a talk on the return of individual research results, ethics, and the common rule. This is the next episode, the next installment of the Translational Research Ethics and Applied Topics talks, the TREATS talks, which are offered by the Bioethics and Subject Advocacy Program, which is a program of the Indiana CTSI. I am Peter Schwartz. I'm the director of the Center for Bioethics here at IU and of the Bioethics and Subject Advocacy Program. And again, it's my pleasure. These TREATS talks are aimed to be introductory for people who don't know much about the topic or who need a brush up. And they're meant to tell you sort of the key things you'll need to know as you think about this topic and going forward with your research or otherwise being involved in research. The talks are recorded and they're placed on our website along with supporting documents and things you might want to know, as well as a copy of these slides. And let's see if I can make this one go forward. Boom. Okay, so I have no conflicts of interest to report. I have to, though, start off by thanking Amy Waltz from the IU Human Research Program and Sandy Pruka from the Department of Medical and Molecular Genetics and Genetic Counseling, who are leading the group with me, which is updating the IRB guidelines on this topic. Amy kindly invited me to participate in that project, and it's been an outstanding learning experience. I'm very excited about what we've done, and I'm looking forward to being able to share those guidelines when they're completed. The members of that working group are outstanding and very helpful, and again, people I've learned from. This is the part I thought Eric would like. I didn't know he'd be here, but I do also want to mention that the last person to give a talk as part of the TREATS series about return of results was Kim Quaid, my lovely colleague, now passed away, who had great expertise in this area and gave excellent talks on the topic, and there she is. Okay, so the traditional view about research and return of results is that there's a sharp line between healthcare and research. In one, we have patients who are receiving healthcare, and the other, we have research subjects. Now we use the term participants. The goal of the activity is, again, bifurcated. In healthcare, we're concerned about treatment and prevention of illness and disease. In research, we are concerned about scientific and medical progress. Those are the goals. These goals and the difference between them results in a difference in responsibility toward the individual. In healthcare, the main responsibility of the team and healthcare providers is to improve and protect the health of the patient. In research, there is also an obligation towards the individual, but that is not to protect and improve their health, but instead simply to minimize and avoid harm to them as participants in this project of research. Similarly, again, due to this bifurcation, there are different reasons why a person participates. A person receives healthcare, approaches the healthcare institution to receive healthcare because they want to improve and protect their health. It's a self-oriented choice. Research participants approach and presumably are supposed to be understood as participating in order to benefit future patients. This is basically an other-oriented stance of type of altruism. So when results arise in research, we sometimes group them into three categories. There are the primary findings, those for which this research has been designed. The secondary findings, those which are also collected but are not the primary goal of the research. And incidental findings, findings which are not expected or pursued but may arise. And any of these sort of results can have important implications for patient health. For example, just to grab a few here, maybe the most obvious ones, the ones that are part of our paradigm of thinking about return of results. In genetics, we might find, as one of these types of findings, if we're doing genetic testing on participants in a research study, that they have the BRCA, the BRCA1 gene, which carries with it a lot of risk for breast cancer and ovarian cancer especially. And so that has important implications for patient health. If you're doing an X-ray, a radiology, a CT scan of the head, you might find a brain tumor. You're not looking for it. The study isn't designed to be looking for brain tumors, but incidentally, you might find one. Lab tests you might find in the process of doing some basic labs, the patient has a very dangerous dangerous level of potassium. 7, for instance, runs a very high risk for the patient of having a heart problem that day. Even something as simple as doing a survey to assess a person's depression, the PHQ-9, may indicate a level of depression which is actually worrisome, even a risk of suicidality. In the traditional view, mentioned before, the idea is results are really not to be returned, since again, the participants are not patients and the product is not healthcare. There's a possible exception for these safety issues, things like a potassium of 7 or of suicidality, and those have been disclosed through time in various ways to protect the participants. However, anything else has been covered by an explicit statement, generally in informed consent, that a participant will not receive any results. And again, I'd call this traditional. You might think traditional means ancient or old, maybe early 20th century. Eric can correct me. He has more of an institutional knowledge and experience with the old days. The older years of research before I became involved. That up till recently, actually very recently, this statement, general approach to return of research results was common. There have been some changes. First, there's been a reconsideration and evaluation of the ethical issues, where if we have useful information, potentially useful to individuals participating in research, is withholding it, failing to disclose it, a form of harm. I mentioned that if there's a residual ethical obligation towards research participants, one of them is to not harm them. And so I think ethicists and others, regulators, started to think, and researchers, started to think that perhaps keeping this information, if it was in their hand, would be a form of harm. And this raises an ethical duty of the duty of rescue. Where, for example, you're running for exercise tomorrow, staying 6 feet away from anybody around you, and you see a child about to walk into the street, many would argue that you have an obligation, not just an option, but an obligation to try to stop that child due to the great benefit to him and the minimal risk of burden on you. You didn't come into the situation with any obligation, but just because you're in a situation where you can benefit somebody that much with minimal risk or burden on you, you have the obligation to do it, and perhaps some of these results might fall in that category. Second, we've seen a blurring of the line between healthcare and research. So if we had this bifurcation, this picture from before, that's been replaced by understanding there's a blurring. For instance, recognizing that clinical trials, although they are research, may be part of the kind of care a person is receiving. Also, research involving electronic health records and other sorts of retrospective studies have looked and conducted research on healthcare in a much more direct way, again, blurring that sharp line between the two activities. Third, there's been a changing view of the research participant. So where we used to call them subjects, we now call them participants, seeing them more clearly as being active partners. There's been a growth and increased recognition of the importance of community-based participatory research, where the community involved, those who are being studied or who are providing the subjects who are being studied are actually active participants in design and carrying out the research, not just as subjects or even just as participants, instead as partners. Third, we've had a changing view of how to reimburse patients and participants in research, and the idea that where we thought of it before as an altruistic act, there could be an understanding where participants are being given more valuable items in exchange for their participation, in exchange for their altruistic act, perhaps which goes beyond simply recognizing their act, but maybe in some sense reimbursing them. For this, you see my other treats talk, and which we I think have up now, about paying research participants and the ethics around that. Another thing that happened to these previous traditional view, which I think I didn't say, I'd say maybe standard until about 10 years ago, say 2010. Again, Eric might have a better date for me about when the view started to change. But one other change that's happened in the last decade or two in medicine and in research has been the growth of genetics, and basically the growth of situations where we collect information that may have great impact on patient health through research. This arose first, probably in thinking about incidental findings in clinical care. The American College of Medical Genetics and Genomics in 2013 came out with a guidance that said that when performing a whole genome or exome sequencing, for any reason, 56 genes should also be checked. And if there are actionable variants that carry some risk, then those variants should be disclosed to the patients. The idea being that although this is incidental findings, these are not the goal of doing the test, they should be collected because they're so easily collected and they may have such a positive impact on patients who are undergoing this kind of testing. And the idea, again, is that this is independent of the reason for testing. It's focusing on the importance of collecting and paying attention to incidental findings, what we previously considered to be optional incidental findings. ACMG argued that actually it should not be seen as incidental at all. It should be seen as key and should be shared. There was a bit of a debate over whether that should be an optional item for patients or whether it should be something recommended. I think probably, well, to be honest, the standard now is that it's a standard, but there's an opt-out option. Now, admittedly, this is the clinical setting, however. Their guideline has to do with a clinical setting. The question how to switch then over to the research setting. And there's been a lot of questions about that. Does the same principle or something like it apply in the research setting? Different groups had to find their own way. Geisinger, which is a healthcare system in Pennsylvania, primarily or exclusively, started a biobank called the MyCode Biobank, and they went out to their patients and they asked them, if you participate in this biobank, do you want these incidental findings, these genetic findings, to be disclosed to you? It's a research biobank, but we will be sequencing your genes. Do you feel people participating in this biobank should be told something about the genes that are found? And what they found was that patients wanted that data. They felt that if they're going to participate, it should be given back to them. Again, helping to evolve this view of whether research results should be given back to individuals. And the guidelines in the end did endorse returning some of these findings back, and I'll go through what that is here. Plus, I should mention, again, in 2016, very recently, the common rules updated and informed consent documents were recommended to include, I'll quote here, a statement regarding whether clinically relevant research results, including individual research results, will be disclosed to subjects, and if so, under what conditions. So now, as part of standard informed consent, there has to be a disclosure about the return of results. Okay, so that's my introductory part. Now I'd like to give you some basic guidelines on thinking about you and your research perhaps, and whether to return the research findings that you may collect. And I'd like to introduce this with 4 bins or groups of findings, characterized in the way I'm going to do here. This is a standard approach. There's a bit of a difference among people on how to separate the findings. Let's go with 4. The first group of findings, I'm going to step back here and close the door for some quiet. The first group of findings are those which are significant for the person's health in the near future, potentially involving risk of death or severe morbidity, and where there are interventions that are available that can improve the outcomes. So again, important findings with important possible interventions. Second bin, you could say, the second group of findings we should think about, there are findings that are significant for the person's health, but not in the near future, not in the immediate future, and where there are interventions that are available and that might improve outcomes. So the first group are those safety labs, a potassium of 7 found today, or a survey finding, a research instrument finding suicidality. That's in bin 1. There's a risk right now. There's something to be done right now. Bin 2 would be findings that are significant, but not in the near future, where there's time, and there are still, though, interventions available to improve outcomes. Bin 2 would be more like the BRCA gene. Bin 3 would be findings that are significant for the person's health, but where there are no interventions available to improve outcomes. And so while there's information here, there's also nothing clear to do, nothing clearly beneficial that you can share with the patient to be a change in their health care. And here, for example, you might think about something as important as a person's Huntington's disease status. You know, a test which, again, Kim Quaid spent a good part of her career performing these tests, but one where there is some complexity over whether a person really needs to know it because there's no currently no cure or treatment that delays the onset or the impact of Huntington's disease. And so something like that would fall on bin 3. Bin 4 would be findings that have unclear significance for the person's health, and where there are, again, no interventions to improve outcomes, but where a person might be interested. So these might be uncertain findings, genes that have certain associations that we don't really know what they mean yet, perhaps some sort of carrier status, something where the person's health is not clearly affected, where perhaps we're still doing research to figure out what the intervention, what the impact is and possible interventions. So basically completely unknown. As you think of these 4 types of research findings, then you can separate the moral pressure, or at least the considerations of what should be done with them. For each of them, we have to think about the benefits of disclosure, medical or personal, the risks of disclosure, possibilities of misuse, possibilities of causing anxiety. And as you go down this list, of course, you can see that you have sort of decreasing clarity in the benefits that you might expect, and in some cases, down in 3 and 4, I'd say, some increasing possibility of misuse, where the use is not known and any particular possible use might be actually a misuse. So one way to split this up with the moral code is to say that, therefore, the bin 1, where there's such a clear benefit, that these are ones that should or must be disclosed to participants or providers. It may be a strong should, or it might be a must. Second bin would be things which you should disclose. There is a possibility of impact, and so this is the ones which some would argue should be disclosed. Bin 3, where there's information that is clinically valid, but where there's no clear clinical utility, no clear way to act on it. These are ones which you might consider to be an optional issue of disclosure. And finally, the 4th category, where there's no clear implication of the finding being considered, then this is one where, as part of research, there is, some would say, if they should not, that giving it to subjects is a negative or a potential negative. So that's my summary of the 4 types. Of course, there's many caveats and considerations here, which I won't be able to cover fully. I'm happy to have a conversation as soon as we're done. I'll be done within 5 minutes. We'll have plenty of time for concerns, questions. We can't cover all this here, but that's the basic structure of what I wanted to present. For any of these categories, if there is any push to disclose it, of course, we also have to take into consideration the limitations of the resources, the effort involved, and the expertise available to the research team. It's not ethically required to look for findings that might fall into one of these bins, this duty to hunt. So where the American College of Medical Genetics and Genomics said that you should look for those 56 other genes and disclose them, these genes that really would fall in bin 2. In research setting, there's a general understanding there's no duty of that sort. If you have the result, you may have some duty to disclose it, but going and looking for it separately than the process of doing the research is not necessary. For results that are not a part of the research, which might be valued by patients, that may be something that could be pursued and returned to patients as inducement for participation. That seems like a reasonable idea about our participants who might be very interested in certain genetic results, and there could be a choice to obtain and return results in order to satisfy that curiosity of really any of the bins. In each stage, of course, benefits and risks of disclosure have to be carefully considered. As you saw from the common rule requirement, a patient must be informed about this, and before any results are returned, consent is important. So there should be some explanation of what kind of results they can expect and the system by which it would be returned. And they must be asked also, so the system being who will return it, how will they explain the results, and what kind of follow-up care or implications might these results have. And I should say here, I'll go back here for a second, that this first idea that patients should be offered results and should be asked for consent is important for really most of these types of results. We cannot return lab results that were obtained in a non-CLIA lab, so a lab that would not be suitable for clinical testing. There are regulations around this. There's a bit of a debate going on whether those regulations will be updated, but there should be great concern and reasonable care in returning any results or thinking about returning any result that was not collected at a lab that's CLIA certified. There's a danger, of course, of returning results that are not clinically valid or aren't carefully connected to the patient involved. There are no ethical or regulatory requirements about who has to look at a scan, and again, no duty to hunt, no idea that each scan must be reviewed by a radiologist. There is no obligation to return results obtained during secondary analysis of research. Again, if you think about the duty to return results as being one that arises out of the duty to rescue, a person who's later looking at data after a study is completed, when the patient is no longer, the participant is no longer present, it may have been years, that duty certainly goes away after some period of time. So I'll try to bottom line. I've said a lot of things. I've stuck to my time. I'm proud about that. But I'll give you your bottom line outcome here. And this is basically what Kim said in her equivalent talk a bunch of years ago now. So first of all, you want to anticipate results that may be relevant to your participants' health or desired by them, right? So anticipation, planning ahead is the byword for this work. Second, you should decide whether you'll return those results. Try to proactively decide what you'll return, what you'll offer, and taking into consideration there some of the things I've spoken about here: the category of the results, the type of result it is, and the implications it might have, the benefits and risks of disclosing it, and being very careful about the process to return and the resources required, whether you actually have them. And third, to disclose the plan during informed consent and allow participants to decide what they want to receive, at least for bins 2 through 4. We've had a bit of a discussion about this in the ethics world and in the regulatory world also now. I've learned about whether to give people the options, when to give people options, and of what sorts for each type of data. I would say once you're in the bin 1 area, where you're doing what you might consider to be safety labs, then it does seem like a situation where offering a participant the opportunity to sort of not be told if they have a life-threatening condition is probably not one that we would offer or consider to be ethical. In that case, you would say, well, if you can't agree to learning about your potassium of 7, if we find one, then we'd recommend you not participate in this research. There are resources out here. This is an area of a lot of work and thought by scientists, regulators, and ethicists. There's a terrific report from the National Academies of Science, Engineering, and Medicine in the U.S. on this topic, and I've got the link here. The Multi-Regional Clinical Trials Center at the Brigham and Women's Hospital in Boston at Harvard did a report on return of individual results. That's also excellent. And actually, our own Sandy Pruka from the Department of Medical Genetics here at IU was a co-author on that, and she brings that expertise. But I recommend her report from before when she came to IU. And the next opportunity I got to mention, just because I am a representative of the Bioethics and Subject Advocacy Program, is if you've seen this talk and I've mucked it up, which is possible, even probable, or if there's just more that you have, more questions you have, please come and visit our website. Go and look at the resources, which we'll have linked there. Also ask us for a consult. And so we are always happy to talk to people about thinking about those proactive steps we recommend in terms of planning your research and planning your return of results to your patients as needed, both for regulation, which we're quite aware of, and also for the ethics of what you're doing. And that is my talk. I will handle my own. Actually, I will not even have. People should just yell out. Oh, wait, no. Wait. I'm enjoying myself. Hold on, guys. This is too good, because now what we can do is we can do raising hands with Zoom. I've learned. Oh, see, I thought I'd learned. Show manage participants. Here we go. Oh, this is beautiful. Oh my gosh. Okay, so we've got all these wonderful people here, and you can just yell out if you want. or you can just raise your hand and I'll call on you. I now have a actual way to see if you raise your hand using Zoom. I gave a medical school lecture 2 weeks ago where 185 students participated in conversation by raising their hands. So please, anybody and everybody, but actually I will say the first question has to come from Dr. Meslin. Whether he has a question or not, he must ask because he has come all this way from Canada at risk to his personal health. So, Eric Meslin.
Great talk, Peter. I can't use the hand raising option because I'm actually using my iPhone. So if I got out of turn, that's sorry about that. I'll do the comment thing and then the question. I really like the talk. You had sort of dropped a little, has it changed over the years? And I would just say that 10 or 15 years ago, this was not the view. I mean, the view is quite a protectionistic, err on the side of not disclosing, the hard distinction that you described, the really cut and dried distinction. And I guess I turn that into a question for you. What do you think, or maybe the others on the call, what do you think accounted for the change? Was it, and it could turn into a multiple choice, lots of patient demand, concerns about overprotecting patients without asking whether they really wanted to be protected, CLIA stuff. The answer is it could be all the above, but I'm as interested in what you think contributed to that change in thinking from a very protectionistic and benevolently so view to one where we're not thinking exactly the same way. And like Diane Rehm, I will go mute and take my answer offline.
I see. I like the finger. So yeah, no, I won't say much. People can make their own comments on this. I will share my experience being at some research ethics meetings, the LC meeting a few years ago in Framingham, Connecticut, Farmington, Connecticut, near Hartford, at the Jackson Labs. And there was two groups there. It was really fascinating to watch. There was a group saying, of course we're not going to give people back in clinical or research settings all these uncertain results that will cause anxiety, be misused. And the other half of the meeting was standing there yelling at them saying, don't tell us what we can't have. Don't tell us what our researchers can't give us when we participate. We'll take it and we'll take our risks. And again, I would just say, Eric, what you said was very lovely. Is this just a delayed revolution? The end of, if you say the modern bioethics, movement was to end paternalism and give patients rights, then perhaps this took 30 more years, 40 more years, and then the research participants made the same revolution and said, don't tell us what we can have. We want what you think will help us, what we want, what we think we want. In fact, those focus groups by Geisinger and then lots of other research in this area shows that people want a ton. They want it all. They want to download their data. They may be misinformed about whether it'll be useful to them. In fact, my colleague, Colin Halverson, who's on this call, is currently just recently published a paper showing that the way people use results of genetic testing, admittedly in a clinical setting, is not the same as they expect. In fact, maybe less helpful to them than they expect. But again, people say what they want. And so, Eric, my first answer will be perhaps this is just the growing of the idea of medicine, both clinical care and research, as being a partnership rather than a one-way street. But there are a million other answers too. David Hass has his hand up next. I love this. I love Zoom. I may never go back to giving talks in person for two reasons. One, I know everybody's name because it's next to their microphone. And two, I know the order of hands. So David, go ahead.
Sure, thanks, Peter. You should have somebody teach you about the whiteboard function. It's even more cool within Zoom. But it's really great to hear that. I loved the talk, and it's so good to see you, Eric, because you and Peter totally got me thinking years ago about these ethical issues and the complexities in pregnant women, particularly. But my question was mostly about the distinction in your four bins about significance in the lines between bin 3 and bin 4. Because what is significant, I think oftentimes is in the eye of the beholder. And the timing of this topic is great because we've had talks with many people about things like environmental pesticide exposures and things like this, where there are association studies hinting at things. And do we give results back when the exposure's already happened? We don't know if moving, I mean, people are going to panic and sell their house and move someplace. And I have a lot of angst between my research ethics discipleship of you guys and wanting to give people back information. And yet the clinician in me feels like, okay, the research team's going to give people this information that we don't know how to interpret. We don't know what levels are dangerous, and we have absolutely zero we can do about it other than create panic. And so trying to figure out where that bin 3 and bin 4 line is, I think is really tough. And maybe I just need an ethics consult from you guys, but I wonder if you could talk a little bit more about how you make that distinction in whether findings are significant or whether the significance is unclear. And I'll go ahead and
finally. Yeah, much less considering actually learn how to use a whiteboard. I can't even figure out the sharing the screen part. I think you should all be seeing now the 4 types of research findings. And David's excellent question is, well, where do you draw these lines? 2 versus 3 and 3 versus 4, who knows? I was actually, in writing this talk, I was thinking, I should say there are no, evidence-based interventions. But of course, in so many areas, we operate beyond evidence. We consider interventions to be important and perhaps even recommended without, for example, randomized controlled trials. So I'm just going to agree with what you said, David, which is that the number, distinguishing between 3 and 4 is a judgment call, and distinguishing even between 2 and 3, I'd say, is certainly a judgment call. And so there can only be, returning to Kim Quaid's principles, planning ahead and doing some reflection. I don't know if you need an ethics consult. We're always here. We're happy to talk it through with you because we've thought about it a few times. But there's no formula, David. You're right to say that. And there will only be a thought and care and then disclosure to the participants. There was one more thing I was going to say about this. Also, I will say this. One thing I've been very impressed by, I think our whole working group at the IRB, again led by Amy Waltz, Sandy Pruka, and myself, has been to how many dimensions these things can vary on. David, you're a OBGYN. Your research involves complications of pregnancy and medication use and care, pharmacogenomics during pregnancy. And of course, there the potential impact of findings and their possible uses are on a different angle than where I think of things, of course, in the adult world, or where, for example, a Mary Ott would think of things in the pediatric world. So your point is well taken, and I just will say that. Before turning to Dr. Storniola, who I am very proud to have with us, I know Eric's excited too. I can see it there. Dr. Storniola, you are next. Anna Marie. You are still muted, though. Your microphone is open, but perhaps your other microphone is not. Oh, I see. Anna Maria's microphone has been. Now we can. Please go ahead.
Okay, great. Thanks. I had to just a minute. I have to turn you off on the.
Yeah, I'll take care of that. Did I mute you? I can't mute you. Wow. Okay. Good. You did it. Good for you. Go ahead.
Okay. So first of all, it's such a joy to see Eric's lovely face. He also took us on a journey. So my question is about the CLIA labs and when that intersects with genetics. So in other words, when we do RNA-seq, et cetera, we do get genetic answers, but none of that is done in a CLIA certified lab. So what are my obligations there?
outstanding question. I'll take a stab at it. Eric's welcome to jump in. He may know the details here more. It's very interesting about the CLIA labs. We've been down this road now with this regulatory discussion. Oh wait, are we good? We've lost the echo. We had a little echo going on there. Actually, Anna, I think you have to turn off your iPhone. Something happened when you turned on your iPhone. I don't know why that is, because you have your computer off. But anyway, so it's simply the CMS regulations are that you cannot return non-CLIA information. Not only that, you can't even say, according to what I've been told by good regulators and lawyers, you can't even say, hey, we found something in your CYP2C19 gene. We can't tell you what it is, but you should go and get that checked out in a real lab. Even that would be considered offering clinical care based on a non-CLIA result, which violates regulations. And so the short answer to your question is that no, if it's not a CLIA lab, you can't return it. And we know of some genetics researchers who therefore collect a second tube of blood and put aside resources if they're available, to run the CLIA test for the finding that they have noted in their non-CLIA lab. If there is no CLIA test, simply unable to return it. Now, we've heard from others, university level guidance, that they will return non-CLIA results if they are significant enough, in part due to a risk-benefit analysis, that basically the risk of not returning something so important outweighs any regulatory risk of returning a non-CLIA result. But the short answer, Dr. Storniola, is that it's according to regulations now, returning non-CLIA results is not allowed. Eric, am I off base here in Canada or in the U.S.? Are you familiar? Or John Bowman may be able to comment as well. That's as far as I understand the regulator. So the ethics of it, of course, is more of my area, is that you would hate to return a result where, for example, due to it not being a CLIA situation where there's any kind of loss of chain of custody and the result didn't apply to this person, it seems to me on an ethics basis that I'm with the universities who want to return the results anyway, or at least say, look, this is something to go get checked out. We can't tell you for sure because it was a research lab, but you really should go get this checked out because it's in bin 2. It's something very significant, or God forbid, something in bin 1, where you really have a result that really has to do with the person's health right now, and where you just felt gagged to not be able to say anything. It seems to me the ethics involves the risk and the benefit of that kind of disclosure. The risk, now involving the risk of the test being not clinically valid, but the benefit being perhaps very significant. Eric?
I don't know that I can add much to that, Peter. I think you said it. John may be closer to the ground on this, but what struck me about Anna Maria's question, and nice to see and hear you too, Anna Maria, is slightly off topic, but watching COVID-19 explode all over the place, there's been a pretty robust discussion about how those tests are going to be evaluated and if they must be evaluated in a CLIA lab and what are going to be done for them. So it's always been a pretty straight line. If it's not in a CLIA lab, you can't disclose info up one end of your tree if they haven't been if they've been in a CLIA lab. That's what CLIA regulations are for. I think you're kind of not waffling. That's not a comment about you. I think you're exactly right that the regs haven't caught up with public demand or public expectation, and probably not clinical expectation either. I mean, if there's a hard no, we will not disclose because we said so. You're not about to have a philosophic discussion about the origin story of CLIA regs and say this is what they're supposed to do. They're supposed to protect people against unwanted disclosures that aren't valid and aren't clinically actionable. I don't know if John probably has more on that than I do.
Well, John has nothing to say on the ethics involved. He can only speak to the regulatory issues. And I think that the wording in the new common rule is very precise as to some of the limitations. The exact wording is a statement regarding whether clinically relevant research results, including individual research results, will be disclosed to subjects, and if so, under what circumstances. Obviously, the key question there is clinically relevant. And I would say the determination would have to be is whether or not the results do meet that standard.
Thanks, John. Am I on? Yeah, I am on. John, thank you so much. Terrific. Wow, this is an all-star cast today. Just terrific. Other questions? Meg, I think you had your hand up. Colin, I'm going to ask you to participate if you'd like. I know it's an area our assistant professor, Colin Halverson in the center, he may not be in a position where he can actually join just verbally, he may be traveling. But we have, a lot of interest in this. I will say that, some of the largest ethics centers working with CTSIs have seen this as their bread and butter. Getting back to really David's question too, for a number of years, one of the most common consults has been thinking through the question of what is the significance of the results and what is the ethical obligation or the proper ethical stance to take. Okay, but I will give people another 1 minute and then we will close it up.
Can you hear me?
I can. Colin, welcome. Go ahead.
This is Colin. So I think the only thing I've been thinking this for a number of comments about how to differentiate the different buckets or types of research findings. And I think I just kind of want to underscore again, I think what you've been saying, Peter, is that my appreciation both of the role of policy and of the role of ethics is to lay out the thought process for this, but then coming to conclusions about where a specific result falls in any of these things, whether it reaches some level of evidence that warrants it to be considered clinically actionable or clinically meaningful, I think is outside of the purview of the ethical consideration. And if you're lucky enough to have an MD and a PhD, then maybe you can do both of those things. For the rest of us, though, I think this is definitely the point where I just kind of take my hands off of it and say, this is how you come to the conclusion, but it's up to you as a clinician, I think, to make those kinds of determinations about whether it actually has clinical relevance.
What's interesting about your comment, Colin, thank you. I'm interested in what you're saying, and we've had some nice discussions about this, why I wanted to hear your voice on this topic, is that I thought you were going to go a different direction. So where you're saying here, it's a clinician's question is what is the implications of the finding. One could say as well that it's equally important to find out from the individuals both what they think of the use of the finding, but then the work you've done now, which I think is so important, is to look at also how they actually use it. Because even if me, Peter Schwartz, with my many degrees and so many letters after my name and a lot of clinical experience says, yes, this is not clinically relevant, I guess you could have a finding where somebody said, no, Peter, actually, I'm going on and I am actually using this finding in some way that maybe you didn't anticipate. Admittedly, usually when I hear about those ways, I think that they are perhaps inappropriate. But I'm not sure that I get to say. And so I do think there's this continuing process of engagement between those of us who have the clinical skills and experience and perspective. But then, of course, I've got to admit, despite my sometimes paternalistic attitude, that maybe there's things that I can learn as you are learning in your qualitative research about how people are using the results. Maybe some of that would change, which bin some result goes in. And I think that's just really important work when one is trying to put findings in these different categories.
The thing that I think you're pointing to mainly that I think is very relevant from the thing that just got published from my old cohort classmates at Vanderbilt is looking at how patients use or what patients consider to be useful information.
Yeah. And
the key takeaway from that paper is that patients are really, or participants are really overly ready to say that they find the genetic test results to have been useful or meaningful, but when they say that, it doesn't mean the same thing for them as it does for the clinicians. And so they're not actually doing anything with this information. They don't understand it. And if they are doing it, one of the current projects I'm working on at Vanderbilt, I think is going to find, or at IU, I think is going to find that they're not making recommended decisions about their healthcare on the basis of the information because they don't understand it. So I think that is a big caveat to what I just laid out, and I think the same thing goes for clinicians too, where I've seen specialists go now.
Okay.
Anyway.
Thanks, Tom. Thank you for playing. Okay, we're losing some reverb here now. It may mean it's time to go. Zoom people are asked to quit. Why am I reverbing? Okay. I'm gonna stop though. Thank you. I can mute my phone. What's going on? Okay, guys. Thank you, everybody. See you, Eric. Thanks to all for participating. And I'll send you, just for the last slide, I will remind you that if you're seeing this online, recorded in the future after the COVID epidemic, and we have survived it and gone back to normal life, please do call us here at the Center for Bioethics at any of these sites. Bye-bye.